So our second speaker is Dr. Kandace McGuire. She is the Program Director of the Breast Surgical Oncology Fellowship Program at McGee Women's Hospital of the University of Pittsburgh Medical Center, as well as the Director of Pre-menopausal Services on the Women's Breast Cancer Program, and as well author of numerous scientific scholarly articles. She did her medical training at Eastern Virginia Medical School, her surgical residency at Thomas Jefferson University in Philadelphia, and her breast surgical oncology fellowship at the Moffitt Cancer Center. She will be discussing trends in breast cancer, asking, is less more or is more more? Dr. McGuire.
Thank you all for having me here today. Typically surgeons are very brief, but I will try to give you as much information as is necessary to sort of update you in the newest trends in breast oncologic surgery. Let's see, I have no disclosures, unfortunately. So on the side of less is more, I think the biggest thing that has come out in breast oncologic surgery in the last 2 years is the state of axillary dissection after the findings of ACOSOG Z11 were made public. And sort of some background on that. If you look back to ACOSOG Z10, what that proved, along with numerous other studies, is that a negative sentinel lymph node biopsy meant no axillary lymph node dissection was necessary. It was just not of benefit to patients who were node negative. However, a positive sentinel lymph node was universally accepted as an indication for axillary lymph node dissection. 2 articles were published noting the results of ACOSOG Z11, and these have raised questions as to the effectiveness of axillary lymph node dissection in node-positive patients in regards to their local regional control and overall survival. So if you look at the design of ACOSOG Z11, basically patients were eligible with a biopsy-proven breast cancer who were clinically T1 or T2 node negative and obviously non-metastatic. They went on to lumpectomy and sentinel lymph node biopsy, and actually if they were node negative, they were then offered entrance into Z10. However, if they were node positive, they were offered entrance into Z11. They were consented and randomized to either axillary lymph node dissection or no further axillary surgery. All of these patients got whole breast radiation and adjuvant systemic therapy, and then were followed up to look for overall survival and disease-free survival. What you can see here is that they randomized about 891 patients, and this was much fewer patients than they originally anticipated randomizing, and we will talk about that later. The intent to treat sample, the 2 arms were fairly similar. We had 420 in the axillary lymph node dissection arm and 436 in the sentinel lymph node only arm, and the actual treatment received sample, there were fewer in the axillary lymph node dissection arm. Some patients refused ALND after they were randomized. And what you see here are the results. So, our solid line here is axillary lymph node dissection. Our dotted line is sentinel lymph node alone. And you can see for both outcomes, overall survival and disease-free survival, no significant difference. If we look at that in tabular form here, you can see when evaluating for local regional recurrence, whether it's in breast, regional, or overall, you can see that the sentinel lymph node biopsy alone arm, 2.8% patients experienced a local regional recurrence versus 4.1% for the axillary lymph node dissection with a p-value of 0.11, so non-significant difference. When you look at overall survival, you see a very similar story here. 92.5% of patients were alive at 5 years after a sentinel lymph node biopsy in standard treatment versus axillary lymph node dissection where we had 91.8% of the patients alive, with a p-value again of 0.25, non-significant. When you look at disease-free survival, again, 83.9 versus 82.2, non-significant difference. Their median overall follow-up was 6.2, 6.3 years, still sort of a short-term follow-up, again, something we'll discuss later. So when we look at this in terms of hazard ratio, what you can see is either unadjusted or adjusted. If you're looking at the actual hazard ratio number, it's strongly in favor of sentinel lymph node dissection alone. However, when you look at the confidence interval, you can see that both of them cross 1. which most statisticians will tell you means this isn't a non-significant finding, that you can't really make any clinically relevant conclusions based on this. But I think the authors of the study argue that if you look at the very worst, you have basically a favoring of the ALND at a ratio of 1.3. And when you're looking at differences of 0.1 to 0.8% overall survival, local regional recurrence, a 1.3 ratio really is not clinically significant, and thus at the very worst, sentinel lymph node dissection is going to treat patients just as well as ALND. So the conclusions of the study was that there was no significant difference in disease-free survival or overall survival between patients who had just the sentinel lymph node biopsy and were found to be node positive, then went on to standard whole breast radiation, or those with the sentinel lymph node biopsy followed by ALND. There were patients to whom this did not apply as well. Those patients who were older, who had ER-negative tumors and did not go on to have adjuvant systemic therapy, those all were associated with a worse overall survival by multivariable analysis. And this study overall just did not support the use of ALND in limited nodal metastatic breast cancer, and the role of the operation, as the author stated, should be reconsidered. There were a lot of criticisms for this study. It's extremely controversial. I think we talked about it at every surgical oncology meeting for the last 2 years, and people continue to put out papers about it. So the study was closed at interim analysis for 2 different reasons. There was a low accrual rate and there was a low event rate. I think the low accrual rate is common to every surgical study that we have regarding breast cancer. Women do not want to be randomized to what surgery they're going to have. We have a surgery in stage 4 breast cancer study put out by Seema Khan where we're seeing slow accrual because of a similar thing, and you see that in every surgical study. However, we also see a low event rate. Local regional recurrence, death from breast cancer in these patients who are clinically node negative is very rare no matter what you do. And so looking at both of these, the interim analysis, the study was closed when they had accrued approximately half of the patients they intended to. There's also a relatively short follow-up time, about 6 years. We all know the biology of breast cancer, especially ER/PR positive, early stage breast cancer. These patients, you really want to look out 15, 20 years before you make any solid conclusions about local regional or overall survival. And these results cannot be extrapolated to patients who are undergoing mastectomy or who don't fit into this very small box of the patients who are eligible for this study. However, these criticisms really don't condemn the study. They just offer us opportunities for further investigation. So, some of the ideas have been subset analyses. Should we look at different tumor types, invasive lobular versus invasive ductal? Very few of these patients had invasive lobular cancer. Receptor status, the grand majority of these patients were ER positive. Should we do a separate subset analysis in the receptor negative patients? And what about the oncotype scores? What did these patients have? Terry Mamunis did a study looking at oncotype scores in relationship to local regional recurrence and found a significant association between the two. Is that something we should look at when we're deciding whether to go back for our node positive patients? Also, we definitely need a study to study this in regards to patients who are undergoing mastectomy and are not going to receive chest wall radiation or are going to receive chest wall radiation post-surgically. And I think that is actively in the works. We don't know if this study applies to patients with larger tumors. T3, obviously T4 tumors were not involved in this study, so that is another opportunity for further investigation. And one of the more popular advances of the last 10 years has been accelerated partial breast irradiation. And this study does not apply to these patients. This was whole breast irradiation with standard, standard tangents, meaning, that you're probably hitting most of level 1, some of level 2, but what about the patients where they're getting partial breast and you're getting no axillary scatter, you're getting no axillary radiation? Does this apply to these patients? Is systemic therapy alone enough to control their axillary disease? And also, what about ultrasonographically positive or suspicious lymph nodes? This study was performed in an era where ultrasound of the axilla was not common. And we don't know whether if you find a lymph node by ultrasound that looks suspicious and you biopsy and it's positive, do those patients have the same burden of axillary disease as those where they are completely clinically node negative, including axillary ultrasound? University of Pittsburgh did do a study. Brian Boone headed that up, and what he found was that patients who have ultrasonographically detected axillary disease, when they go on to have axillary lymph node dissection, they do actually have an increased burden of disease versus those who are completely node negative. However, we have no data to suggest that there's any difference in clinical outcome between those two groups. If you were to admit axillary lymph node dissection in the both of them. So that is a study that needs to be done. I think Jessica Benson-Haver at University of Michigan also had a very similar study that she presented at the Society of Surgical Oncology in 2012, showing that patients who have ultrasound positive axilla do have more disease, but does that translate into a worse outcome? We're not sure yet. So, like I said, very controversial study, but many people were excited about the opportunity to limit the morbidity of axillary surgery. We know that patients who undergo axillary lymph node dissection have between a 20 and 30% risk of lymphedema. We have nerve damage, permanent numbness. We have limitations of activity that patients and practitioners would really like to limit. Can we shunt these people into sentinel lymph node only arms? And many people have adopted these findings. If we look at a national study of the American Society of Breast Surgery, there was a survey study that went out to see who has adopted these findings and how they've done that. And if you look at the participating providers, what you see is that most of the providers are actually private practice, general or oncology surgeons who are also performing breast surgery. The minority of them were academic breast surgeons, and then sort of the next largest was the private practice breast only population. Then they went on to ask them how did they find out about the findings of ACOSOG Z11. Most of them actually said that they got it from an ASCO press release or American College of Surgeons or ACOSOG. About 30% of them actually read the original article as their first exposure, and then there were a number of other methods by which they learned about the study. Now, whether they learned about the study and then went on to read the original article was not asked. So next, the investigators went on to ask, well, now that you read the study, is this going to change what you're going to do? Would you perform axillary lymph node dissection in the following situations? So when you have a patient, your classic Z11 patient, 1 to 2 positive lymph nodes, who was undergoing breast conservation therapy and whole breast irradiation, would you offer an axillary lymph node dissection to that patient? And you see that most people said that they would infrequently do that. There are still some that said they would never do it. There are some that said sometimes, and then there are some that still would say all the time or most of the time. But the grand majority of the respondents would never or infrequently perform an axillary lymph node dissection in these patients. The next was sort of the extrapolation of the findings. So you have the same exact patient who's undergoing accelerated partial breast radiation. And what you see is a very different scenario. Most people are following the findings of Z11 to the letter of the law, at least the respondents to these studies. About 35% said they would all the time offer axillary lymph node dissection to these patients. Another almost 30% said most of the time. So the grand majority of people are offering ALND for these patients, since we have no data to support that they shouldn't. And then we looked at the same patient who was getting no radiation and even a stronger response in favor of ALND. So this was encouraging in the fact that people were adopting these findings but not attempting to extrapolate them to patient populations that were not studied. This was not the first time that this was evaluated. It was the first time it was done prospectively, but if you look retrospectively at the SEER database, Yi et al. Did that in 2010. They found 26,000 patients between 96 and 2004. in that population, these were node-positive patients, and then they determined whether they went on to completion axillary lymph node dissection or not, was actually omitted in about 16% of patients. Those patients tended to be older, undergoing breast-conserving therapy, smaller tumors, had micrometastasis, which is a completely different study and subject that's probably outside the scope of today, or at least my talk. They had low to intermediate grade tumors, and they tended to be ER positive. So, our smaller, well-behaved, quote-unquote, breast cancers, people were omitting these before the findings of ACUS-OGSI-11 were made public. They also looked at the National Cancer Database and found about 97,000 patients in the same situation, and they found 20% of patients, or almost 21% of patients, had their completion axillary lymph node dissection omitted in the setting of a positive sentinel lymph node biopsy. Very similar characteristics: older, smaller tumors, lower grade, ER positive. And what they found was that there was no difference in local, regional recurrence or overall survival. However, the big limitations of SEER studies and NCDB studies is that we don't have complete radiation or adjuvant systemic therapy information about these patients, and a lot of the clinical pathologic factors you just don't know. But this was a good starting point. So this is certainly not the first time that we've heard this, and people have been obviously practicing in this way for a long time. So, is less more? Good question. The actual adoption of this outside of the membership of ASBS is yet to be known. And really the further study needs to be done to see whether these rates of axillary recurrence are the same when used outside of a clinical trial, when people start using their own sniff tests on patients, when they start trying to extrapolate this and push the edges of what we found. Do we find that we have a marked rise in local regional recurrence or a marked decrease in overall survival? That's yet to be seen. And we also have to see within the context of this clinical trial if long-term these patients will perform just as well. So to flip the coin from less is more, now we're going to talk about as more. So as intervention in the axilla becomes less and less invasive, surgery of the breast seems to be becoming more and more so. There are definitely increasing rates of mastectomy and contralateral prophylactic mastectomy, both nationally and in certain centers we see it even more so. So the background, just to get everybody up to speed, obviously we all know NSABP-B06 and numerous other trials showed the equivalency in survival between breast conservation therapy and mastectomy, despite the fact that there's a slightly higher local regional recurrence rate in patients undergoing breast conserving therapy. So a smart young lady with the last name of McGuire, when she was at the Moffitt Cancer Center, decided to look back at their experience, and over a course of 13 years and 6,000 patients found that breast conserving therapy was initially very popular, as it had been nationally, and this trend persisted for many, many years until about 2003, 2004, when a change happened, and why that change happened is something that we're still all trying to figure out. But you can see a sharp decline in the breast conservation therapy rates, and obviously a mirrored increase in mastectomy rates. Basically they met in the middle here at 2006, and what you can see is that early in the study period, 1994 to 2003, 65% of eligible patients underwent breast-conserving therapy, whereas when you look from 2005 to 2007, 60% of that exact same patient population with no clinical pathological variables that are different underwent mastectomy instead of breast-conserving therapy. Moffitt was not the only place to see this. The Mayo Clinic has also seen an increase in mastectomy after seeing a slight dip in the early 2000s. Some people have said that this was due to MRI, and Katapamula et al. Did note that there was an increase in MRI over that same time period. However, when they evaluated who had mastectomy, they found that they were no more likely to have had an MRI than those patients who underwent breast-conserving therapy. So not only is mastectomy increasing in some centers, most notably the center where they don't see this trend is Dr. Huddis's institution, Memorial Sloan Kettering, where they've seen a fairly solid trend in breast-conserving therapy since its proof of principle in the 1980s. However, contralateral prophylactic mastectomy has been something that's universally on the rise. When again you look back to our SEER database, you see from 1998 to 2003, the overall rates of contralateral prophylactic mastectomy have increased 150%. In those patients who needed a mastectomy on the affected side, it's increased 162%. The patients more likely to choose or to undergo contralateral prophylactic mastectomy are patients who are younger, have lobular cancers, are white, have a higher education level, and have a family history of breast cancer. And again, this may harken back to some of the limitations of the SEER database. We do not have information about patients' BRCA mutation status. We don't have information in regards to how strong their family history was or any of those other sort of influencing factors. What you can see here that Tuttle et al. Found is that stage for stage, no matter what stage we look at, patients who were eligible for any surgery, breast-conserving surgery or mastectomy, their rates of contralateral prophylactic mastectomy increased from 98 to 2003, no matter what stage we're looking at. And an even more dramatic rise can be seen in CPM in those patients who required mastectomy of their affected side. So why? Why is this happening? Is it surgeons who are suggesting it more? Is it patients who demand it more? Where is the onus here? Certainly public awareness is a big issue. People are more publicly aware of celebrities who've undergone bilateral mastectomy. They're more aware of the concept of familial breast cancer and BRCA mutations. They advertise BRCA analysis on the television, and patients come in and want to know why they haven't been tested and should they just have both breasts off because I'm sure I must have that gene. And is it the improvements in mastectomy and reconstruction? A lot of papers looking at this have shown that the availability of high-quality reconstruction can increase patients' desire for CPM or for mastectomy in general. And the advent of nipple-sparing mastectomy in the last several years, that's become more and more popular. Certainly when your cosmetic outcome is better, one can surmise that you're going to be more likely to undergo a larger procedure. And it's hard to argue that when you go from this to a skin-sparing mastectomy, which looks pretty darn good, to a nipple-sparing mastectomy, which looks pretty awesome, that you can't argue that patients are going to be more likely to have a lower bar for proceeding with more surgery. However, there are several other reasons why we surmise patients might be requesting CPM. And at Pittsburgh, we've had a pretty constant rate of CPM amongst mastectomy patients of approximately 25 to 26% for the last several years. So we've studied this pretty extensively. One of the things that we found, Sobrero et al. Looked at this, of the patients who underwent mastectomy and had a preoperative MRI, 12% of those patients require biopsy, and only 2% of those have an additional cancer either in their ipsilateral or contralateral breast. So certainly just the very act of the MRI increases patients' likelihoods of undergoing mastectomy and contralateral prophylactic mastectomy, but doesn't necessarily increase their survival. Generational differences in attitudes towards breast conservation. We've certainly seen that as the patient population ages, that those of the older patients have a much greater desire for breast conservation than younger patients. And why that is, we have not been able to ferret that out just yet. At UPMC, we took a look at this, and the most common cited rationale for undergoing CPM was fear of recurrence. Also, the influence of spouse, family, and surgeon also were important. And as I was saying before, availability of high-quality reconstruction, genetic testing, influencing factors as well. And despite the fact that these patients may not, in our estimation, need this procedure, 97% of them are very satisfied with the outcome, and 96% would make the same decision if offered the opportunity again. We're not the only people to have found this. Frost et al. Looked at this in the year 2000 and found that, again, the grand majority of women were satisfied or very satisfied, and would, again, repeat the same decision if offered the opportunity. Again, this overestimation of benefit of CPM is really crystallized when you look, I think it's right here, where she says, "I'm very happy with my double mastectomy. I have never regretted it, and I am free of worries about breast cancer." And what this reflects is the patient's underlying misunderstanding of their risk of recurrence. Certainly, contralateral prophylactic mastectomy reduces their risk of local regional recurrence. It reduces the risk of occurrence of breast cancer in the contralateral breast. But really, the largest risk to life is their distant recurrence rate, and this does nothing for that. I think very few patients understand that, and that may be where our opportunity for education in regards to this issue is. If you look at Isabel Bedrosian from MD Anderson, she looked back at their experience with contralateral prophylactic mastectomy and found that the only patients that enjoy a survival benefit from this surgery are patients who are in the 18 to 49 year category. And again, they were not able to look at BRCA mutation status, so this may be largely a reflection of BRCA mutations. So in conclusion, like I said, I promised I would be brief. Is less more? Should we be doing less axillary surgery? Another extremely controversial topic as of late has been margin width. If you look at the original NSABP studies, the accepted margin was no tumor at Inc., and those are the studies that showed equivalence between breast-conserving therapy and mastectomy. However, numerous other studies, small institutional studies, have suggested that we need wider and wider margins. Some people will even say for DCIS you need a centimeter margin, sort of misinterpreting the results of the Van Nuys criteria. And then what about surgery after preoperative chemotherapy? There are some patients who have an imaging complete response. Do those patients need to undergo surgery? Would additional biopsy in combination with other adjuvant therapies be sufficient for them? And these are all things where active research is going on. And then the big question of is more more? I think most of us can argue that more is probably not more, at least oncologically, but psychologically maybe it is. We have the mastectomy and CPM issue, which I think that debate will continue to rage. We have oncoplastic surgery, so removing large volumes of tissue in a way that is cosmetically pleasing, which usually requires surgery of the contralateral breast for symmetrization. Is that an opportunity for patients with larger tumors to undergo breast-conserving therapy and maybe enjoy the benefits of the Z11 findings? And then, again, preoperative chemotherapy. More and more patients are undergoing preoperative chemotherapy in order to facilitate breast conservation or for some theoretical reduction in risk, but is that where we're headed in terms of surgery and medical oncology? So, in closing, I'd just like to thank you all for having me here. Hopefully I've helped crystallize some of the issues in surgical oncology of the breast in the last couple of years and not completely confused us all. And I'd like to thank you from the beautiful city of Pittsburgh and answer any questions.
So, I have a question, and you discussed MRI as a promoter of more extensive surgeries. It was very interesting because we're also living in a society that's questioning the value of screening MRI at the very same time. And I was wondering what your view is on screening mammograms and MRIs, and maybe ultrasound should be added to every mammogram, at least ones with dense breast tissue.
Well, so I think overall, for the grand majority of the patients there, and this has been borne out in a couple of studies, that there really is no benefit to adding MRI or ultrasound to screening mammography. However, there is the patient population who is dense breasted, and those patients may even be at a higher risk for breast cancer. That's still controversial as well. For those patients, I think certainly mammography can often do them a disservice. They end up with multiple unnecessary biopsies, or we miss cancers that are there. I think those are the patients where we really need to look at whether additional evaluation with MRI and ultrasound is recommended or necessary. Really, right now, the only patients that we screen with MRI are going to be patients with lobular carcinoma who are premenopausal and BRCA carriers. The NCCN guidelines only suggest MRI screening in those patients. Ultrasound screening is a whole other ball of wax. It's so operator dependent. I think University of Miami was in development of an automated system for ultrasound screening. I really think that we'd have to have some standardization of ultrasound in general to make it a good screening tool. If you look at all the Dutch studies, the three modalities together were the best, but certainly that's extremely expensive. So I think we need to target those interventions to patients who will benefit from it the most, like the dense breasted patients and those with a high risk for breast cancer.
Great talk. On the less is more theme, for sentinel lymph node sampling for the patient with the single positive sentinel lymph node, going back to get additional nodes for prognostic information versus if you remove 3 or 4 sentinel nodes at the time of your original, do you not go back and get more?
So it's difficult to go back and get more, especially if you've had recent surgery. They've already had a mapping, so really repeating a sentinel lymph node has never been proven to be effective, at least in that small, time frame. Generally, if this is a your standard metastasis, a macrometastasis that doesn't have extra capsular extension or other poor prognostic features, we will accept the one lymph node. Because when you're in there doing a sentinel node biopsy, you're not just looking for whatever's hot and whatever's blue, you're looking for palpably suspicious lymph nodes as sentinel nodes as well. And if you don't see any of those, I think you have to give that patient the benefit of the doubt. I think probably what I didn't express in the talk is that we're not saying that sentinel node biopsy alone is equivalent to axillary dissection because we're leaving them with no additional disease. We know in 27% of those patients they have additional disease. We just hypothesize that systemic therapy and radiation therapy treats that residual disease. So if you go into that with that mindset, then I think you feel much more comfortable omitting the axillary dissection in the patient in whom you only get one sentinel node. It certainly makes you feel much better, though, if you get a few more.
The other question is preoperative or pre-neoadjuvant sentinel lymph node sampling. Are you routinely doing ultrasound-directed FNAs or cores, or how do you approach the axilla?
So, again, that's something that's in evolution. There was a recent trial that just closed, and I think we're going to get some data from that at San Antonio or maybe even ASCO Breast, looking at sentinel node evaluation following neoadjuvant chemotherapy. And it's basically in node positive patients, have you converted them to node negative, and can you predict that with a sentinel node biopsy fairly accurately? Until the results of that study are known, what we do, at least institutionally, and it seems like most places that we've talked to do the same, is we do sample pre-neoadjuvant chemotherapy. And if we find disease there, then without good data to support an alternative method of analysis afterwards, we proceed with an axillary lymph node dissection. We do not do sentinel lymph node biopsy pre-chemotherapy, just axillary ultrasound and FNA or core.
Question. I really do love the idea that you at least showed a little line of oncoplastic surgery. As a plastic surgeon, our society is really going to push education awareness this October, because we still feel we're lagging behind. In Pittsburgh right now, as you educate women who have lumpectomy, how many of those actually get to see a plastic surgeon ahead of time? And if so, are you starting to select them out about the patients that are going to be more unsatisfied are going to be re-excisions and medial tumors, and some of those women will likely be unsatisfied with lumpectomy. As that word gets out, that will certainly drive more patients to mastectomy when reconstruction is a little more commonly talked about in that arena versus the lumpectomy arena.
Right. So I think, as you likely know, I mean, the patients who are best suited for oncoplastic surgery are those with a large breast, where we can do some sort of rearrangement of tissue. Either the most common thing would be in combination with a reduction mammoplasty, and so I think those are the patients that we are referring to plastic surgery there. And there are all other ways to sort of replace tissue, but those are just so complicated. It is a very long run for a short goal. So probably about 15% of our patients breast conservation patients, are we actually attempting some sort of combined procedure, or at least having that conversation with them. The grand majority of them just probably wouldn't benefit from it.
And most of those, I assume, are going to be a C size or larger. That way you can easily do things.
Exactly.
And it's not worth transporting things in or
Yeah.
anything else, when obviously the adjuvant therapy is critically important for survival.
Mm-hmm.
But I think as we move forward, the quality of life is going to become a bigger issue.
Absolutely.
Thank you again for nice talk.
Thank you.
Dr. McGuire, in women with a positive sentinel node who you've done breast conservation on, and you're not going back for a completion axillary node dissection,
Mm-hmm.
what are your radiation oncologists doing for their radiation fields? Are they treating the breast only, or are they contouring the axilla and treating a full axillary? Or do they say at their meetings, we don't know what to do?
So we are following the way that, in theory, things should have been done in ACOSOG, and we believe that they were done in the Z11 study, which was just standard whole breast irradiation. But we know even with that, you're getting, like I said, some level 1 and some level 2. But we do not give them full axillary radiation, because axillary radiation, comes with its own, lymphedema risk, which can be up to 15%. So no, they're just getting whole breast radiation, no axillary tangents. Thank you.